Initiate the GI and hepatobiliary assessment by evaluating the pulse. Tachycardia suggests anemia or hypovolemia. Low bradycardia is a classic sign of obstructive jaundice. Assess blood pressure for a wide pulse pressure, which indicates cirrhosis. Low blood pressure may signal underlying sepsis or an acute UGI. Inspect the skin for spider nevi in the superior vena cava territory, specifically the head, neck, and upper chest. These telangiectatic vessels feature a central feeding arteriole that blanches with pressure. Examine the hands for palmar erythema and clubbing. Leukonychia, presenting as white or teres nails, is a significant indicator of chronic liver disease. Evaluate endocrine changes, such as gynecomastia in males. This presents as a palpable subareolar nodule of approximately 4 centimeters due to an increased estradiol to free testosterone ratio. Observe for Dupuytren's contracture, a sign of chronic alcoholism. It involves fibrosis of the palmar aponeurosis, causing flexion contracture of the ring and little fingers. Perform liver palpation using the preferred method with hands lateral to the rectus. Feel for the liver edge as it descends with deep inspiration. Calculate the liver span in the midclavicular line. A normal span ranges from 6 to 12 centimeters, while a shrunken liver suggests advanced cirrhosis. Screen for splenomegaly using Cassell's method at the lowest left intercostal space. Dullness on full inspiration in the anterior axillary line indicates possible splenic enlargement. Utilize Hackett's grading system to quantify splenomegaly. Grade 5 represents massive enlargement where the spleen extends towards the pubic symphysis. Detect ascites by testing for shifting dullness, which requires at least 1.5 liters of free fluid. Observe the transition of the percussion note as the patient turns to the lateral decubitus position. Assess for a fluid thrill, which typically appears when acidic fluid reaches approximately 2 liters. A positive thrill indicates that the ascites has become tense. The SAAG, or serum ascites albumin gradient, is the gold standard for differentiating portal hypertension. A gradient greater or equal to 1 grams per deciliter predicts portal hypertension with 97% accuracy. Test the direction of blood flow in dilated abdominal veins using Harvey's sign. In portal hypertension, the flow is typically upwards above the umbilicus and downwards below it. Grade hepatic encephalopathy using the West Haven criteria. Asterixis, characterized by irregular myoclonic lapses of posture, is a hallmark of grades 1 and 2. Diagnose HRS if serum creatinine exceeds 1.5 milligrams per deciliter without improvement after volume expansion. Type 1 HRS carries a poor prognosis with creatinine rising above 2.5 milligrams per deciliter.